I have no financial disclosures at this time. Just by introduction, we have 20 vein centers interspersed between Maryland and Northern Virginia, along with Washington, D.C., and 4 outpatient-based angiography centers interspersed. So in 2013, we saw approximately 9,000 venous patients amongst our practices. And why is pelvic congestion so important? Because when you're practicing venous disease, as my colleagues explained here, it's an art, and it's very important to take it very seriously. Pelvic congestion syndrome affects up to 15% of women between the age of 20 and 50 years. Amongst that population of patients, they have insufficient veins in their pelvic, in their pelvis, but not all of them have symptoms. But 60% of them can present with symptoms, and that's why it's very important to be cognizant. Oftentimes, they'll present with pelvic discomfort, which is nonspecific. Now, this can present in gynecological offices and OB-GYN doctors' offices and account for about 10% of the population. Unfortunately, it can be underdiagnosed because of the limited appreciation. By no means do I want to make a statement that when you have a patient with pelvic or pelvic pain or pressure that they have pelvic congestion. This pie chart shows that pelvic pain can be presented in various ways, whether it's GI, urinary, reproductive, or musculoskeletal. It's very important to rule out the other causes before we proceed on to looking for pelvic congestion. So what is pelvic congestion by definition? It's the retrograde flow of blood, just like venous insufficiency in the legs. It's venous insufficiency in the pelvic area, leading to incontinence, leading to dilatation of veins, and engorgement. The features, typically it's a chronic syndrome, so patients will typically have symptoms for more than 6 months. Typically, it's located in the lower abdomen, sometimes mostly in the pelvic area and in the lower back. It can be correlated with dysmenorrhea because of the fact that the increased levels of estrogen can cause dilatation of the veins, and dyspareunia. This can lead to severe functional impairment, believe it or not, because of the symptoms. Anatomically, the pelvic area has a complex network of anastomoses, and it's important to understand that within the area of the bladder, the vagina, the uterus, and the ovaries, these are all interconnected. They all drain into the internal iliac system. Major portal of drainage of the left ovarian vein is the left renal vein, and the major portal of drainage of the right is the inferior vena cava. The normal caliber of the ovarian vein is typically less than 5 millimeters, so that becomes important when we're further evaluating this. Again, the symptoms, dull, achy pain that can be constant or intermittent, sometimes interspersed with stabbing, sharp pain. Now, this is important. This pain, discomfort is worsened as the day goes on. As the patient is standing, walking, prolonged sitting, any type of increase in intra-abdominal pressure. It can be, typically it's on the left side, but can be generalized diffused into the right side. And again, it is associated, or can be associated with sexual intercourse. And again, it can be perimenstrual. So on physical exam, oftentimes when you have the patient and you're evaluating them, you can see that this patient has the dilated varicosities in the anterior thigh compartment that make their way up. How do we diagnose this? There's a variety of ways going from the least invasive to the most. We typically start with a pelvic ultrasound. Laparoscopy can be performed. Typically, that's done in the OB-GYN realm. CT venogram, MR venogram, or venography. We typically start with the pelvic ultrasound, and what we're looking for is, and I'll start by saying that it's important to have the patient standing to have the gravity component. And we're looking for tortuous dilated veins in the pelvic area. Typically, they're adnexal. Slow flow, sometimes you'll even appreciate some reflux in the area. And oftentimes, you'll see dilated veins that are crossing the pelvis, as you can see in this picture. Oftentimes, again, patients are coming to us after being evaluated by the OB-GYN doc, and they'll bring pictures with them saying that, hey, my doc said that I have dilated varicose veins in my pelvis, and here's an illustration of what they'll look like. The gold standard is selective ovarian venography. And in this picture, you'll basically see cannulation of the ovarian vein. Typically, an abnormal ovarian vein is greater than 10 millimeters in diameter. If we were looking at it live, what you'll see is on prolonged imaging, you'll see kind of the contrast being stagnant and pooling in that area. I'd like to go into a case presentation as the final part here and kind of tie it all together. What we have is a 46-year-old female college professor who's very well polished. Basically came in, again, complaining of lower abdominal pain, pelvic pressure, generalized over the past 3 years, has been evaluated by many, many specialists, multiple OB-GYN doctors, multiple pain clinics, and nothing has really improved her discomfort. Worse around her menstrual period. She did also notice her left leg worsening and swelling over the year to the point where she cannot wear shorts or a skirt. She also noted varicose veins in the inner thigh. Otherwise, no significant pathomedical history, no significant surgical history. She does have 3 healthy children, all vaginal deliveries, evaluated by her gynecologist. However, there were no pertinent findings, actually multiple gynecologists, and all the testing came back within normal limits. So how did she come to us? She was referred to our vein center for the varicosities that were in the thigh. And this is what she had. So as you can see, you see the dilated varicose veins making their way in medially and going up into the inguinal area on the left side. This is the vulvar area here, and you can, again, appreciate the dilated varicosities in that area. So what did we do? We started with the superficial venous ultrasound, and surprisingly, it showed minimal axial reflux. So we did not see a whole lot of GSV or SSV reflux. So at this point in time, it doesn't, red flag should go up. Well, physically, this patient has all these dilated veins and these symptoms, but by ultrasound, we're not picking anything up. So at this point, the symptoms are way out of proportion to what we find. So what do? Do we put them in compression stockings and follow them and bring them back? Do we rescan them again, bring them back at the end of the day when the veins are maybe more dilated? Or do we just do, phlebectomy to the varicosities? No, the answer is none of the above. Pelvic venous duplex is very important in this scenario because what we need to do is we need to evaluate evaluate for pelvic venous outflow problems. In her scenario, basically what we found was a significant reduction in diameter in the left common iliac vein. Now, don't let me fool you. This is not an easy ultrasound to perform. It requires highly technically skilled ultrasonographers to do this test, especially in the pelvic area. The ultrasonographer also noted dilated varicosities in the left adnexal space that did appear to have some pooling of blood there. So what did we do next? We had to go and do a further invasive evaluation. So we took her to the lab and we did venography with possible IVUS. So I know my colleague before did a great job explaining a May-Thurner syndrome, and on the right side here you see the standard bilateral injection venogram. You can appreciate some haziness in the left common iliac area, which is most likely adjacent compression from the right common iliac artery. We went ahead and did IVUS because, if we're going to do this, it's very important to do it with IVUS. And as you can see, comparing it to the reference segment on the right, there was a significant amount of compression, greater than 70%. So next what we did was we went up into the IVC, cannulated the left renal vein, and then selectively cannulate the left ovarian vein, which drains into the left renal vein. In doing that, what we did was we injected down the ovarian vein, and you can see it's a large stalk, dilated. Again, that ovarian vein should not be more than 5 millimeters, and that's clearly, if the catheter's 2 millimeters, that's clearly upwards of 10. Also, what you can see laterally is that large stump that is opened up of collateralization, which is clearly not normal. Going further down the left ovarian vein, we're into the parauterine plexi. You can see dilated clusters. They look like clusters of grape when you actually stand on cine for a prolonged period of time. You actually see the contrast just staying there, mimicking the flow of blood or lack of drainage of blood from that area. So what do we do in this scenario? We go ahead and do embolization therapy. Embolization therapy can be It's a joint thing. It's chemical and coil. So what we first do is down in this area, we inject sodium tetradecyl sulfate, or STS, 3% solution. Very similar to the solution we do to treat the sclerotherapy in the legs. At this point, after we inject that, we do it in a protocol form. And once we do that, in this scenario, I decided to coil the left ovarian vein because of the fact that it was so large. I will tell you that if it's not large, I'll typically just do the chemical embolization and leave it be. But in this scenario, I decided to go ahead and do the coil embolization. And what the coil does is it's going to clot on contact, and we're basically closing that left ovarian vein off. And very similar to the lower extremity, by closing down the refluxing vein there, the blood is naturally going to get rerouted into the healthier veins and thereby improve the drainage in that pelvic area. On the way out, what we did was we then addressed the May-Thurner compression, and we went ahead and ballooned and went ahead and deployed a stent in that left common iliac vein. And this was our final picture. Now, at 1 week follow-up, I will tell you these patients will have discomfort, typically abdominal and lower back discomfort, and we forewarn our patients ahead of time and make sure that we have them on Percocet, PRN, and Motrin over the counter as needed. In her scenario, in 6 weeks, she had no further heaviness or pelvic pressure that she was experiencing. At 3 months, the varicosities went down on their own, so there was no need to do any type of phlebectomy. At 6 months, her left leg swelling completely resolved. And I will tell you, I've been doing this for about 3 years now, and we've done over 250 patients like this, and it is a life-changing experience. You want to talk about it, not having to live with this. I mean, these are typically otherwise young, healthy females who have never really been sick in their life. They've never been to hospital other than just to, deliver their babies. So it can be a traumatizing experience for them. But we've enjoyed doing this, and again, we're doing all of this in the outpatient setting. And so with that, I thank you very much for your attention.